Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfang, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. If this is your first time tuning in to Breast Cancer Conversations, I'd love to send you a huge welcome. If you're an avid listener and tune in week after week, I am so glad you are joining us for another episode of the podcast. Today, I am so excited because I think this actually might be a Breast Cancer Conversations first, where we're actually talking with a physical therapist who specializes in oncology. I am so excited for today's conversation. I learned so much, and I know you guys will as well. I also want to give a quick shout out to our nonprofit, survivingbreastcancer.org. So again, if this is your first time visiting us, you might not know, but we have a whole slew of resources that are available to you absolutely free, from weekly meditations, journaling, expressive writing, weekly support groups for all stages and all subtypes. I would encourage you to sign up for our weekly newsletter so you never miss a beat. So without further ado, let's get started. Welcome to the conversation. Welcome, Derly. I'm so excited to have you on our podcast, Breast Cancer Conversations, today. This is a podcast where we provide education, support, hope, inspiration, and most importantly, an opportunity to talk with the experts to educate our cancer community on all of the amazing things that are happening out there in the world that we might or may not know about. So today we are going behind the scenes with Derly Munoz, who is a physical therapist in the oncology space, which I am really excited about because a lot of us actually don't know all of those amazing support mechanisms and people we have in our back pocket to help us throughout the cancer journey. So I'm really excited to shine the light on physical therapy specifically for oncology. So Derly, thank you for joining us today.
Absolutely. Thank you so much for inviting me. I'm very excited.
Fantastic. So tell me a little bit about your background, first of all, and maybe giving us a definition. What is physical therapy? Because I know sometimes we, rightly so, confuse physical therapy sometimes with occupational therapy or all the other different types of therapies out there. So tell me a little bit about specifically physical therapy and then how that relates in the oncology setting.
Absolutely. So I'm original from Colombia, South America. That's why this kind of nice, cute accent. So I've been here for like half of my life. I did physical therapy back in Colombia. And what physical therapy does is really rehabilitation of your functioning regarding like walking, moving, be able to get back into your kind of like your daily activities. Like, you can use the steps, you can go back to the gym, you can, after any kind of injury, it's really kind of like getting you back into where you used to, where you were able to do prior to whatever injury or disease or whatever happened to you. It can be as simple as you just fell and had an ankle sprain and you just need to get back into walking to get back to work, to having a total joint replacement, to oncology, which, yes, you're right, the physical therapy in oncology is fairly new. However, has been out there. I've been doing this for 14 years, so has been out there maybe for the last, I want to say 17 years or so. Lately, it's a lot more popular because the American Physical Therapy Association finally got a specialty as a board specialty certification in oncology about 3 years ago.
Oh, wow. So very recent.
Very recent, exactly. So now definitely we are growing and growing and growing more, and more people is knowing us, and we are really part of the whole interdisciplinary team. So it really is amazing how not that many like clinics had it, really. Like, it's really hard to go to a place and say, I would like to work in oncology only as a physical therapist. And they're like, wait, we don't have an oncology program. Like, you will see some cancer patients, but you will see your orthopedic patients or the patients that you're working on your shoulder pain or your total knee replacement, but it's not just oncology. And I'm like, what? What do you mean you don't have an oncology program? I'm doing this in my clinic for for a while. So it's amazing how big institutions don't even have that.
Right. And it's so interesting what you're bringing up too. And we notice this a lot in healthcare in general, especially with, drugs and FDA approvals and clinical trials. As you were mentioning, this practice might have been around for, you've been practicing for 14 years. It might have been around for 17 years, 2 decades, so to speak. But it's not until it gets into the guidelines, into the standards, that it really becomes that type of practice. And just really thinking how long, and I guess it's all relative, right? Because some people might think, oh, it's short. You finally you got into the standards. But that's when I think more attention gets placed on physical therapy in oncology. And then I was just even Googling before today's conversation, a lot of the peer review journals and a lot of studies and editorials coming out about the importance of having this interdisciplinary approach to helping you with your survivorship and rehabilitation.
Absolutely. And it's funny because when I started doing this journey, so I've been a PT for 33 years. And when I had the opportunity to start working in oncology, I'm like, I have no idea what to do with oncology. Occasionally you see some cancer patients, but I was like, I have no idea. And when I went and shadow a couple of my colleagues who were doing it, I absolutely fall in love with it. And my background is very strong manual therapist. So I do spend a lot of time hands-on. And that was actually exactly what a lot of the patients needed it. So that was really a nice. And at that point was a lot of like, you know about lymphedema therapies, right? So you have a lymphedema therapist and everything was about lymphedema. And I'm like, no, not really, because it's not really lymphedema. This is just one piece of the whole amount of things that can happen to somebody going through a cancer journey. So it has to be more about every single thing that happened on your system that we should be able to intervene to get you back into that nice quality life and back to normal that you want to have after going through a journey like this.
Yes, that's a really great point. And that leads me to kind of my next question. I think you're absolutely right. We are now kind of uncovering, like, if you're having surgery or if you're having a lymph nodes removed, you are at risk, even if you have radiation, at risk for developing lymphedema, which is the kind of the swelling in the body or the tissue. You can probably describe it a lot better than I can, where the lymph fluid doesn't actually move by itself, and you have to use a lot of manual massage. There's a lot of techniques that are out there. I actually suffer from lymphedema. I see a lymphedema specialist. But tell me what else, you were mentioning that's just one small piece of it. What other aspects of physical therapy that we need to be aware of when we're going through a cancer diagnosis?
Absolutely. So I have the fortune to work with great team members, and I'm part of the multidisciplinary team. So I'm in a breast tumor board, head and neck tumor board. So I'm part of that. So I'm listening to the story. I'm not necessarily making any decisions for like if this patient needs surgery or not, but I'm there to say I want to see this patient pre-op. So I think that when somebody with diagnosed can be coming to us right away and we see, okay, what is your baseline? What are you looking like now? You just have a recent diagnosis and you're going to go through this series either of surgery or chemotherapy or radiation. But I want to see what you look like prior to all this. So, number one, we can start to see, oh, you look great. And I want you to continue keeping this up. And I want to keeping an eye on you while you're going through all these treatments to see what deficits I start to see so we can intervene that and kind of get you much better off with some of these reaction or secondary effects of the cancer treatments that you're getting. And as well, we can do a lot of like baseline measures, right? So for instance, we were talking about lymphedema. So a lot of the breast cancer patients see the breast surgeon and right away they see us. So we can do a baseline of your circumferentials and your upper extremities. We use something called bioimpedance to look into your extracellular fluid. We do something called InBody for body composition because we know a lot of the influence of your VMI on your cancer diagnosis or breast cancer recurrence. And then to try to really help you to be healthier to face these treatments that are coming up. And then we'll see you 2 weeks after surgery. So we know, oh, great, you are doing almost the same than before, but we will continue monitor. Or now we're dealing with a scar, we're dealing with lack of mobility, we're dealing with pain, we're dealing with just the fear of movement, right? I didn't know that I can move my arm and I just been really holding back. Or just really prepare you to have the range of motion you need on your arm to be able to go get radiation. or really start to work you on your chemotherapy days, we have a really good program where I try to really do a good exercise program right before going into chemo, because we know that the more we increase oxygen levels into these cancer cells, the more effective is the chemo and the radiation treatment. So I'm really trying to get these patients to like, let's get you guys working out, let's get you working to a high interval training, because it has been a lot of research in regarding high interval training and dealing with cancer related fatigue that is being produced by radiation, chemotherapy, and other cancer treatments. So it's really the whole complexity of, if you happen to have chemo and a lot of those chemotherapy are toxic, and you can have issues with neuropathy, which is numbness, tingling sensations in feet and hands, that can put you right then in a high fall risk, because you don't feel your feet, you can fall, and the last thing we need is you falling and breaking something. So really it's a whole complex of, from what all these treatments can do to you, or just monitor and help you to keep a good exercise program, a good quality life as you're going through all these cancer treatments.
Exercise is so important. And, I'm talking to a lot of, friends in the breast cancer community, doctors, and, it's easy if you lived kind of a healthy, active lifestyle before your diagnosis. And a lot of times we're so angry when we find out we have cancer because we thought we were doing everything right. We thought we were living a healthy lifestyle. And you kind of go through this like, gosh, like, why is my body like revolting against me, so to speak? And so if you have this pattern prior to, I think it's a lot easier to maintain some level of activity. However, if you weren't someone who was actively working out, maybe you had a desk job, you're busy picking up and taking the kids everywhere. Like, it's really hard, I think, especially for some of us women, to prioritize ourselves. How can we motivate someone who is dealing with the trauma of a cancer diagnosis, treatments, radiation, Monday through Friday, and then encourage them also on top of all of this to maybe take a walk, maybe meet with you and get some physical therapy? How do we get someone to be encouraged by all of this?
I think the great advantage we have is because we establish a contact with you guys so early on the diagnose, that they get to trust us. And then because we help them, like, we talk about activity right away, but I understand my goal, if you're about to have surgery with a double mastectomy in 2 weeks, I'm not going to push you if you were not an active person in regarding exercise program, right? Because sometimes people say, but I'm very active. I take care of my house. I walk to the mailbox. And I always say, well, this is just really your ideal. This is just the way of living. I'm talking about an intentional exercise that you go and walk intentionally for like a mile or more than that, or go to the gym or do whatever, yoga, swimming, anything. So usually it's hard at that point to try to sell that to somebody who just is super scared and you're about to lose your breath in 2 weeks, right? So usually we tell them the more you start to move now, the faster is going to be your recovery after surgery. And then, what has been really help us doing this body composition? Because a lot of people has been telling you, yes, you're overweight, yes, your BMI is higher. And when you actually see it and you see, oh my God, all this is fat and all this is muscle, I'm like, I'm in really bad shape. I better be doing something about it. So I think when you see something on a paper, that has been actually a very big motivation to people. Because we have a surveillance program, this actually, we follow patients up to 5 years. So we kind of run this test often. So actually become their motivation. In 6 months, when you do this test, I want these numbers to be here. And they're really excited when those numbers have changed. But in the other hand, we always tell them, what is it that you enjoy doing? Do you like to be indoors? Do you like to be outdoors? If you like to be outdoors and you have kids and you're busy, well, then just take the kids to the park. And then while they playing, then go and walk with them or try to run with them, throw a ball with them. Try to, just so you have a dog, or if you like to do things indoors, try see if you can have access to a little bike or the stationary bike, or like really do a lot of YouTube videos inside the house. With the COVID was a lot of things out there that you can do indoors, that while you're making dinner or you're looking at something on TV or whatever, you can try to really do something, but try to get your heart rate up there. And then we really try to, we see them through this whole chemotherapy, and they see the difference. They come in to us and they're like, I'm like 6 weeks of radiation, my skin is all break out, I can barely do anything. And when they come to us and we treat them, and we kind of get them into that bike, and we get them doing stuff, and we work hands on them, and they feel amazingly different afterward. So right there is like, oh my God, that really make me feel better. Like, see, this is it. Like, you feel so down, just push it. And you go and do your activity, and you do what you're supposed to do. And that's going to make you feel better.
Totally agree. I have this motto where, as I'm trying to get in shape myself and work out a little bit more, even on those days that I don't want to, I get on this bicycle or I do some sort of activity, and I'm like, those tend to be my best workouts, because when I am tired and exhausted and I don't want to do it, I end up just like focusing, and it takes off the stress of the day. It really helps my mood and energy levels. And, I could be sluggish and lethargic and just exhausted. And how easy it is to just want to sit on the couch or watch a movie or do something else. But if I get a little bit of activity, I think it releases those endorphins. It releases like all of that, blood flow, and you're ready to go. And, it doesn't have to be like an hour either. You're not saying go out and run a marathon, 10 minutes, 15 minutes. It just kind of gets the blood flowing.
Exactly, exactly. And really makes a difference. Like, I have a really busy, hectic schedule, but I've been working out all my life. But I do work out on my lunchtime. This is my release. This is my stress. This is my caffeine. It's like, okay, I'm ready to go for the afternoon, even if I just do it 30 minutes, high interval training, whatever, or 20 minutes or whatever. But that really makes a difference. And you're right. When I don't, then by 2 o'clock, it's like, man, I'm feeling it. It's like I'm not focusing the same. I don't have the same energy. So definitely, and again, I have not have cancer, and I'm not going through what you guys been through, but I know what my body feels and needs, and it's nice to feed the body with something that is healthy for you versus feeding the body with something that is not healthy for you. So
Yes, exactly. And so I want to talk a little bit about, some of the side effects that we do experience, right? Because, it's one thing to be on the podcast to make it sound so easy to go for a walk or to work out or do these things. I love the idea of accountability. So it sounds like when you're working with a physical therapist, specifically in the oncology setting, we have someone who's holding us accountable and that we're meeting with every week, every 2 weeks, for 5 years, which is wonderful. So, when I was going through cancer treatment, the fatigue was real. I was exhausted. And, something as simple as like walking to the end of the street just to get to the stop sign, I was like, that's good enough. I'm going to turn around and go home because I cannot make it, 2 blocks. And then also when we're on some of these cancer treatments, I know we're also given some steroids that kind of help us with, managing the nausea and some of the other side effects that actually have, benefits. But then for me, it actually put on a lot of extra weight because I was getting pumped with all of this extra chemical, right? And so I kind of got this like poofy round face, and I was like putting on weight, and my doctors were like, you're looking healthy compared to the opposite where you're losing so much weight. And so how do we reconcile all of this on the like, I always say like every day doesn't have to be a great day, right? You're going to have the ups and downs. You're going to have days where you feel stronger than other days. But how do you, when you're meeting with patients, right, who are feeling all of these side effects?
So one thing that we always look at is lab values, right? So if you're going through chemotherapy, so we need to make sure the body is okay, right? They come to us, and we don't want to be push you if we know your red counts are low, or or your platelets are low. So we gotta be careful with how your system is doing. So we always look at those to see what kind of dose of exercise we should advise you to do. So that's one thing. The other thing is, just because, like I said before, we kind of try to capture you guys prior to your treatments, then I'm kind of really dose you up because you don't have anything on your system yet, right? So we can get you in with us, or with you guys can find anybody out there on the oncology, or not necessarily has to be oncology, but doing an exercise program that has a knowledge in healthcare, right? So you're not just gonna go to a personal trainer that just really training very fit, healthy people, but you can try to find somebody who has some kind of background on disease. And then if you can establish a program from the beginning where you have not too much toxicity in your body, then you kind of feel the benefits of it a little bit better. So when we see patients that they're going to start in chemo regimens, we start to teach them an exercise program. We call it like the chemo protocol. So it's like an exercise program, and we modify depending on what you're capable of doing, right? So if you are a crossfitter, then of course I'm going to give you a program for a crossfitter. But if you really are just a mom, sedentary, or even you're older and you're more sedentary, well, we're going to modify things to kind of get you out of being sedentary, but I'm not going to push you to the other extreme. So we try to kind of get you, like, I want you to come to me before chemo starts so we can get you adapt into this program, and then try to keep it up, and let's see you the day of chemo. First thing, come, let's do a workout, and you go to your chemo. And then 2 3 weeks later for your next cycle we do the same. Now I always tell them, it's an accumulation, so you may feel not too bad on the first 2 3 cycles, and then it's when things start going downhill, and that's okay to feel that way. But try to teach them what is okay to push through and when it is not okay to push through. As you know, it is a time where we call it an adder, which is like, all your counts dropped after, day 3 4, sometimes can be up to the 14th day post chemo. So I usually tell patients, you got to be careful on those days. This is the days I don't want you to push through, because your body is just trying to heal and you can really get in trouble. But after that is no excuse. I want you to push through. You push through the first 5 10 minutes, then you feel like, oh man, yes, I do have more energy. I do feel better. So it's just that regimen, and really let people help you, right? You don't have to do this alone. So if you can find somebody who is accountable, right? Your partner, your family members, your kids, your friends, like, we're doing this together. I'm going to come and get you, and we're going to for a walk together, or we're going to the gym together, or we go swim together, whatever it is. I think sometimes you have that motivator that is pushing you through a little bit through it. And then you're right. We have patients who do wonderful and really minimum effects. And we have patients who end up in the hospital because they have a lot of trouble and they know they have to tap her off, but we bounce back after that recovery. So yeah, so it's just really try to find how can we motivate them and what motivate them, and just try to really just kind of like push through.
One of the things you said earlier on that I'm curious about, actually, there's two questions I have. The first is, after surgery, right? You said that you normally want to see patients about 2 weeks afterwards. And a lot of times, we just had this huge invasive traumatic surgery to us that we're scared to start to raise our arms. We're scared to like pick up a gallon of milk. We're scared to put weight because we don't want to hurt ourselves, right? And so what type of exercises do you recommend, and how soon or late do people start getting involved? Because, at the same time too, we want to prevent the scar tissue from building up, right? So one of the exercises my doctor gave me was this like walking up the wall exercise with my hand and like holding it for a couple seconds and then bringing it down, going back up to as high as I can and then bringing it down. Are those similar things that you work with your patients on?
Exactly. So as we see them pre-op, usually we teach them a few things that they can do right after post-surgery. And then at the hospital, sometimes some of the physical therapists who work in the hospital, we kind of guide them into an exercise program that they can do until they see us. It's really depending on your surgeon. Is certain surgeons tend to be a little bit more conservative than others. It's a lot of controversy. If should we move faster or not for developable seromas or not. So it's really depending on your surgeon. So I think that as a therapist that are listening to this, I think that you have to bring all your evidence base and just really another professional, and you should just, if you know where you're thinking you're doing is right and it's evidence, you just really have to show it to your doctors. And just because they're the surgeons doesn't mean that they know it all, right? I don't know anything about surgery, but I know a lot about rehab. They know a lot about surgery, but they really don't know much about rehab. So I think that it's really depending on surgeons. So in our institution where I work now, our surgeon is all about movement, right? So it's like, and so I always tell patients, if at least something happened during surgery and your surgeon don't want you to move until like only 90 degrees for the first 2 4 weeks, for something happen, then you listen to that, right? But if everything went smooth, it's no rhyme reason why you should hold back on your motion. Now, you have to respect the drains, right? So if you have a drain and you reach too far and that's really pulling, you gotta back up because otherwise you're gonna hurt yourself. But if drains are out, you need to start to push in little by little because otherwise that tissue is gonna become tighter and tighter. So yes, so that little walking up is good. We call it cane exercises when you can lie down and grab a cane and just kind of bring it into flexion and going into abduction and then just kind of like, we go into this protective mood, right? So where your body just goes forward because you just have this big surgery and you kind of like, number one, you're kind of like getting used to not having your breast or only have one breast, or even if you just have a lumpectomy, it's just your body goes in protection mode. So I always tell patients, you gotta kind of like, a patient told me something one time that I love it, like just show the girls, right? Like you just really have to just she just really kind of like really go into that little extension and work on your posture because that's what's going to really stretch a lot of things from the beginning. And then just try to do your normal activities in regarding your showers, a little bit of cooking. Of course, we usually limit our patients to no more than 10 pounds in the first 4 weeks. Besides that, not necessarily go for a run or anything like that, but you can do a walk and you can do, something light. But just go back into your normal activities. So, and sometimes as well is the caregivers, right? As a caregiver, we either allow the patients to do so much, but more likely is not to do that much because we don't want them to be hurting. So I like the family members to come to our appointments because they can hear from us. It's okay for them to move. You have to let them. Otherwise, it's just gonna be really more damage to them, right? Because so it's no reason why you have to bring their breakfast to bed or dinner to bed. They can get up, they can go to the dining room, those kind of things to try to be there. So I think it's just a lot of the education. And when they come to us, some of them are really scared to move for the first 2 weeks, and that's okay. When they come to us, then we guide them we do a lot of like hands-on with soft tissue mobility, scar mobility if we can at that point. Sometimes, just working on your pectoralis or even for head and neck, whatever it is. We try to really address those things and then start to really guide you into now it's okay to do A, B, C type of exercise and just kind of progress you from there.
A couple of fun anecdotal stories. So when I got back out of surgery, and also for people who are listening right now, as you're preparing for your surgery as well, some of the things, as you can tell, I'm a big coffee drinker. And so for me, it was really important to have all of my coffee mugs on the counter because I knew I wouldn't be able to reach up into the cupboard to get the coffee. And so again, to your point of independence, I didn't want my caregivers to have to do everything for me. I'm like, I want all the coffee mugs on the lower counter so I can get my coffee in the morning. But what I wasn't expecting was even picking up the coffee pot was heavy. You realize that gosh, you rely on your pectoral muscles so much for opening the refrigerator, pouring the coffee, doing all of these things. And so, I didn't push myself when it was really, really hard, but then just kind of gauging progress over the week, 2 weeks, 3 weeks, what I was able to do. And then my mother came out to visit me during surgery. She stayed with us. She came out from Chicago. And I remember after coming home from the hospital, the next day I wanted to go for a walk. And she was like, "You can't go for a walk. You just had surgery." I'm like, "Mom, my breast had surgery. My legs are just fine." So, I tucked my drains into the little pouch and everything. And we did a nice little walk just to get some fresh air. And it was really beneficial. So I really appreciate your advice because that was my experience.
Exactly. And sometimes people think, I love what you just say, I had surgery on my breast, not my leg. So remember that the body is connected through your whole, this fascia, which is this sheet that surround every muscle, every tendon, every bone in the body and works all together. So when you start to walk and you try to move your arms, like swing your arms, guess what? You're moving all that tissue on your trunk. You're kind of helping your chest area to really get more loose. So every time you move a hip, you're working on the opposite shoulder. So your body works all together that people sometimes is like, well, I really don't want to do anything because I don't want to do anything on here because it's going to hurt my chest. but it is a big influence from the foot all the way up to your head, that you can really move a lot of your legs, and that's an influence on your chest without having to be doing anything on your arms. What I mean? So the body is amazing and just works all together. So yeah, just don't think that it's just upper extremity that you're being influenced on your chest area or your thoracic spine. Really is the whole body.
It's a really good point. Excellent point. The second question that I have, and I don't know if you know the answers to any of these things, but we hear a lot in our community about neuropathy. And neuropathy, I think, is something that we're aware of when we're going through chemotherapy and treatments, but it is something that can also have an onset later on in years to come as well, right? It could have kind of like a delayed effect. And how does physical therapy either mitigate neuropathy, or if you are dealing with neuropathy, how can physical therapy help support those treatments and side effects?
One, we do a sensation test. So where we kind of like do a little prickle on your feet to see exactly how lack of sensation or how bad feels in there. And then we do a lot of like a strength testing on your ankles, feet, knees, hips, because like I say, all that works together. And many times, yes, you have some muscles on the bottom of your foot that we call the intrinsics of your feet, and those guys has to be strong. And those are the guys who actually grab on the floor when you're standing up. It's kind of like all those muscles on the bottom of your foot tends to like I'm grabbing the floor, right? Because then that's gonna give me balance. Well, when you don't have sensation, because the neuropathy is that it's just kind of some damage on the peripheral nerves, so create lack of sensation, then those muscles are like, I don't know what to do because I don't feel the floor, right? So they just become like blank, they just really become weak and they don't know how to react. So what we try to do is try to stimulate all that sensation again. So by doing some, hands-on, working on your plantar fascia, which is the bottom of your foot, working in all those joints on your foot, kind of like waking things up, and then doing a lot of different exercise with your intrinsic or a lot of the bottom of your feet and as well your ankle. And then from that point, start to work into a lot of balance. And then teaching you different strategies. If you are going to fall, but your feet doesn't feel that much, how can you overcompensate with your hip? Or how can you overcompensate by weight shifting the opposite direction? So we do a lot of kind of like fall prevention to try to help with that. So yes, we cannot really get rid of the symptoms, and when you have a bad neuropathy, it's really hard to always go back to normal. Some people does, some people don't, and can be a few years before you do. But we have seen a lot of success. Is when you find rehab, um, try to help with all those strategies, so that really put you in less fall risk. The other thing that helps a lot is aquatic therapy. So when you are in the water, the hydrostatic pressure push you everywhere. So really give you all that sensation, and then you don't have the fear of falling because you're in water. At least, so that really help to then you can just walk and you can go into the toes and you can do all kind of different things that you feel more comfortable doing in the water, and that really makes a difference because the pushing all over again the place from the water improve your proprioception, improve your balance. It really makes a big difference. So that's a really nice modality to work with that.
Oh, that's fantastic. That makes me so excited. I enjoy swimming a lot. And I remember when I had my drains, I couldn't go into the water for like 4 to 6 weeks. And I was just like, oh my God, I can't wait to just like move my arms again and have that. Even for lymphedema too, I felt like the pressure of the water was so relieving. Like I probably felt my best when I'm underwater.
Well, actually, when you mentioned with lymphedema, the hydrostatic pressure creates 3 times the compression that for a sleep does. So you guys actually can do your manual lymphatic drainage. If people knows what that means, when you're having lymphedema, it's something called manual lymphatic drainage, which is a technique to try to help with that lymphedema. You can do that when you submerge all the way down. So you're doing the 2 things at the same time. You're doing your MLD and then you're doing the compression from the water. So it works really well.
Oh, I'm excited. I'm motivated. Darly, you're so motivating. So like I need to go work out today and I need to move around and stretch and fantastic. Well, so you also mentioned, this is a moderately new modality to have, a physical therapist in the oncology clinic. And for someone, whether you're recently diagnosed or have been living with metastatic disease for a number of years, it's never too late to see an occupational therapist. But how do we find one, especially if our clinic doesn't necessarily have them? Like, is there like a directory or some place? I think you were mentioning a couple like American societies that might have a directory.
Yeah, so you can find is through the American Physical Therapy Association. It's an oncology session. And then we are now, again, I did my board certification in 2020 and I sat for the second group. So I think we had the first one on 19. That's when we did the first board certification. So you can go in there and then find board certified oncology therapists. Now, you don't have to be a board certified to do oncology because a lot of people, I did it for 14 years before I became certified.
Sure.
But you may want to just make sure that that person or that physical therapist is aware of all these different, effects. And, it's not just go to a therapist. And I'm sad to say this, but unfortunately, like everywhere else, right? Same thing with physicians, same thing with anybody that you go. I have some of my colleagues who just, you see patients, they barely touch them and they just give them an exercise program and they come and they do the same exercise over and over and over. And it's like, so patients come to somebody else where we spend hands on them and we're looking at the whole body and they're like, oh my God, I've been in therapy before and nobody ever touched me or do these things, which is so sad because it's like, are you kidding me? Like, that's what we went to school for. Like, what's going on with this? So I think that you go to a place, find out that sometimes lymphedema therapists can be really good when you have a physical therapy background as well and you're a CLT. However, a lot of the times lymphedema therapists can just kind of really sometimes focus just on the lymphedema part versus just kind of looking at the whole thing. So it really depends what your institution is like, what the place is doing. But yeah, but there's definitely just us around, like just being in physical therapy itself. And if you come to your physical therapist, they should be honest and say, I really have no idea about breast cancer or head and neck cancer or whatever, pancreatic cancer, whatever it is. I need you to go. So hopefully I'm hoping that my colleagues out there are really good about let me see who can I guide you through. Let's look at how can I support you to exactly what recommendations we have. Because I'm in Gainesville, we see people from all over the place here, UF, and so we have that. We have people who comes from Tallahassee, people who comes from Georgia, people who comes from different areas, and it's like a one-time eval, and it's like okay, so we have a little list of like some people that try to go into this association and see if you can find somebody in your area. If the therapists have any questions, tell them to reach out to me, and then I'll be happy to kind of have a good sense of like you really have no idea what you're doing, or really that can be a good thing as well. So
Yeah, that's a really good point. And I think that's the benefit of the community as well. So, we have our Thursday Night Thrivers support group. Every Thursday night, we meet up on Zoom, and we have people from all over the country, even some internationals from Canada and South America. And that's where we have the peer to peer advice, right? We're not medical professionals, we're not doctors, we're not giving medical advice, but we're comparing experiences. And I think that sometimes gives like the light bulb goes off. We're like, oh, wow, my doctor is doing this, my doctor's not doing this. Maybe I should feel empowered to ask for something else. And so I really think that's important, especially around physical therapy, where I wasn't offered physical therapy necessarily, or if I was, I don't remember because I'm dealing with so much trauma and I have all these doctors and trying to just get the cancer out of my body. I'm sure they told me a lot of things that I don't remember. But, especially over time, it's never too late to kind of, continue to put these amazing colleagues in our back pocket, as I like to say, is, I want as many people looking after me as possible.
absolutely. And you're right. I think is if you have somebody, the entry of cancer goes through either the medical oncologist or usually the surgeon, right? So if you have a good surgeons who are really proactive on that, like our breast surgeon, she's like, if you don't CPT, I won't do your surgery. This is just bottom line. So it's just really like she is such a big believer. And we do another procedures that is important for us to get baselines to try to do some, I don't know if you have heard about LV bypasses, which is like connected the lymph nodes to the vein at the time of surgery if she is planning to do an axillary dissection, because that decrease the, yeah, well, actually has been out there for like maybe in the States, maybe 9 years. Prior to that, Italy actually was the one who started doing it. So yeah, so we're doing like a, we don't want to call it lymphedema prevention, but definitely we're doing these LV bypasses on every axillary dissection they do. And we actually did a paper on it, and we were able to drop we dropped the lymphedema rates from like 38 to 40%, right? If you have an axillary dissection, to 12%. So that was a really huge difference. So we really, with those particular patients, and she's more picky because we have to have a baseline to be able to see if you develop any kind of increased volume or increased bioimpedance. So I think that if the surgeon is really pro, they will push through it, and I think that will be really the beginning on. But I think as a therapist out there that are start working on oncology, again, like I say, I'm as well a clinical instructor, so I tell my students all the time, you just have to be on that team and just educate the physicians and just open your mouth in those tumor boards and say, I can help with this, or I would love to see this patient, please send a referral or whatever, and just advocate for the patients as we continue growing, and then just kind of start for them to see us as part of the team, and not just when the patient is in a wheelchair or you have a huge arm is when they think about us. So
oh, I love that. Such great advice. And I'm so excited. I definitely would need to pick your brain and invite you back with some of your medical colleagues as well. I would love to dive deeper into the axillary node dissection, some of these amazing techniques that are happening. And so, yes, this has been so eye-opening. I hope all of our listeners, patients, medical professionals, physical therapists, colleagues, around the globe are as motivated and inspired by today's dialogue. So, Darly, thank you so much. This was amazing.
No, thank you so much for having me here. I really enjoy it. And anytime, just feel free to reach out to me, or, you'll have my information for my social media and I have a podcast as well. So just welcome to just really reach out to me anytime.
Fantastic. And we'll link to all of those in the show notes too, so our listeners know how to find you. So thank you so much.
Absolutely. Thank you.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. Our podcasts are made possible because of donations from listeners like you, so please feel free to make a contribution through survivingbreastcancer.org/donate. And there are so many ways to get involved with our nonprofit and our organization, not just through listening to the podcast, but through all of our virtual programming. So you can check out all of our lineups by hopping over to survivingbreastcancer.org/events. And as always, all of our programs, services, and resources are absolutely free. Thanks again, and keep on thriving.